In 2013, about 580,000 Americans will die of cancer. That's almost 1,600 people a day. Cancer is the second most common cause of death in the U.S., exceeded only by heart disease, accounting for nearly 1 of every 4 deaths. That's why the work of the Cancer Institute at St. Francis Hospital, the Heart Center, is so innovative. It brings together essential elements for an integrated approach to treating cancer. Join me today as we discuss Catholic Health Services, Oncology Services. This is CHS, Long Island's health source. Welcome, everybody. I'm Jane Hansen, and with me now is Dr. Kenneth Gold, the co-chairman of Catholic Health Services Oncology Services. Welcome. Thank you so much for being here today.
Thanks, Jane. It's very nice to be here.
And it's kind of an exciting time in this whole world for Catholic Health Services, the world of oncology, because you guys are really integrating a lot of services to, I guess, do a better job overall would be the point at the end of the day.
Absolutely. So we're taking a large system that has 6 hospitals, 2 rehabilitation facilities, a palliative service care, and a hospice, and looking to coordinate our care. We've delivered excellent cancer care at all of 6 of our hospitals, and now we're embarking on a new era where the service line is being drawn together and we're able to share information and best practices.
And when you do that, does it mean at the end of the day the patients will actually end up getting better care?
Yeah, we think so. An example of where we're going with this is, for example, our pathology department, which is very well renowned on the island, will now be centralized so that the cutting edge leadership of diagnosis on the diagnostic side of cancer will be coordinated between the 6 hospitals. And this is a particularly important time for this era in medicine because we're now embarked on an era of personalized molecular-based oncology, so that no longer are we just categorizing cancers when they're diagnosed by their appearance under the light microscope, but particular characteristics of the cells are identified by our pathology department, and that requires great leadership.
Pathologists, by the way, are the people that most patients never see.
These are the doctors that you don't see when your surgeon takes you to the operating room, or when a biopsy is performed, or in some cases when blood is analyzed, in the cases of leukemias or lymphomas. These are the doctors whose job it is to make the call about the cell of origin, to name the tumor, and in the modern era to name it in a very, very particular fashion that looks at the best available information about the molecular drivers of cell growth.
How many times does a pathologist and a surgeon, for example, talk about a patient in a day's time or a week's time?
Yeah, it's pretty remarkable. The conversation can be from the operating room to the pathology department by phone. It's often at conference as cases are discussed. The slides will be projected and the management discussed with a very multidisciplinary team. And CHS hospitals have done a great job of this at our tumor boards and our case conferences.
And so when that happens, it means that with the right diagnosis, you can get treated better, maybe faster, maybe a different approach, all of those things.
All of those things, and it's become very, very important when designing therapies now from the outset of the case to have it accurately categorized. Certain of the leukemias, for example, would be almost, you could not even initiate a conversation about appropriate therapy without knowing very specific molecular information. And so more than ever, the clinicians who care for cancer patients have this very, very close bond with their brethren in the pathology department, the doctors that most patients don't get to see.
It's like, but as you said to me before, lung cancer isn't just lung cancer, and sometimes breast cancer isn't breast cancer. It started someplace else, or it's a different form or something.
It's really the breast cancers or the lung cancers, and even we're now learning that even one cell type, adenocarcinoma of the lung, for example, when you're planning therapy for that disease, once it's been diagnosed, your discussion really has to include information about the gene mutation status embedded within that tumor. That's information that sounded like Star Wars during the years that I was training, quite a while ago now. But it's become state of the art. And when cancer programs are reviewed, the governing bodies, in a very good way, want to be sure that we're collecting the data that needs to be collected so that the right care plan can be made from the very beginning. Once we do that, we have a pretty good sense of the current best therapies. Clinical trials have powered a lot of information about what therapies do work best. But in this era, that decision would be different for example, a breast cancer that overexpressed the HER2 gene. You need to know that information. Or one that was estrogen receptor positive versus negative. You can't make a treatment plan unless you know those specific pieces of information.
But what that means is the chances of surviving, because you're getting very customized care, are much greater.
Personalized medicine is the term that's the term that's being used, and it means that not everybody's case is the same, even to the point where if it looks the same on first cut, there's a whole field now that has come into use, very much so, a field called genomics, in which a group of patients, an example here would be somebody with early stage breast cancer. Estrogen receptor test is positive, the lymph nodes are uninvolved. The medical oncologist is faced with the decision, would this be a good case for preventive chemotherapy doses, or might I just manage this case with hormone blocking medication? We'd prefer not to use the chemotherapy if we knew that it wasn't going to be helpful. 10 years ago, we didn't know. Now you can dig down deeper into the molecular makeup of that cell. So these tests are being ordered right out of the pathology departments in the system. And now you can customize. So for one patient whose risk of recurrence is higher, you might say chemotherapy here would be warranted and is necessary. And for a very similar looking case, prior to the genomic data, you might have an opposite conclusion.
Yeah, it's just amazing what's gone on. Well, as part of this whole integrated system, I know that you've got a relatively new cancer center at St. Francis Hospital, and we managed to go and take a look at that. So here, check it out.
It is really amazing that it's a very less known fact that there is a lot more non-cardiac services that are provided at St. Francis compared to just the cardiology services, which are nationally reputable and well known and recognized, but there are also non-cardiac services that have significantly expanded over the last 5 to 7 years. In fact, there's a very prominent surgical oncology division right here at St. Francis that does cutting-edge oncologic procedures. For us in oncology, we look for providing compassionate, personalized care to every individual. That is a culture that St. Francis and the Catholic Health Services have embraced for a very long period of time. And it is therefore no surprise to our patients and to all the staff that work here and to the community that St. Francis is ranked so highly when it comes to patient satisfaction. So Cancer Institute is obviously in its infancy, but it follows the same mantra as we talked about putting our heart into cancer care. We have different components of the Cancer Institute. There's a outpatient office area where we see patients of different types of cancers, malignant hematology, leukemias, lymphomas, solid tumors, and we have an infusion unit where we are able to take care of these patients with whatever treatments that they require, whether they're biological treatments, conventional chemotherapy treatments, transfusion support, to something as simple as providing them intravenous hydration, growth factor supports. That can all be done as an outpatient in our really state-of-the-art infusion unit. The third component is the inpatient unit, where we've been able to set aside a certain location where our staff, particularly our nurses, are extremely well trained, dedicated, and able to take care of those complicated situations which our patients are dealing with, whether it is, again, a complication of their disease or a consequence of their treatment, or they're actually receiving those high doses of chemotherapies or biological therapies in the hospital. But we have a nurse navigator who's able to be the liaison with the patient if that individual needs a thoracic oncology consultation, the individual needs a certain type of imaging test to be done, or a referral for radiation oncology, is really a key person to navigate that patient's journey through the process, and just to try and take away the anxiety that is associated with setting up appointments and those things which will take a lot of time and effort, while the patient really should be focusing on other issues. I think the other aspect of oncology care is not just the issue of treatments that are delivered while the individual is sick. I think an important aspect that we are all recognizing is that for those that are cured of their cancers, they are now survivors. And we have to give our attention to how we can help them become active participants in society after their treatment is over. And we are really looking forward to setting up a survivorship program for our patients. In addition, genetics is something that we are recognizing plays a very important part in the generation of tumors. Some familial risks, some environmental risks. What are the genetics that an individual is predisposed to that may lead to the onset of disease, and what are the risks that their family members are exposed to, and what can they do in terms of screening so that they can have a healthier life. So we are actively working on expanding our genetic counseling program as well as the survivorship program, and in conjunction with the entire spectrum of care that the Catholic Health Services provides across Long Island, whether it is at Good Samaritan Hospital or at St. Catherine's or at St. Francis, I think we can provide the entire spectrum of cancer care.
And you raised some pretty good points, Dr. Gold, about prevention. That word just caught my attention, because we wouldn't be having to talk about cancer if nobody got it.
Right.
So prevention will always mean that you're going to, catch it early, which is the most important thing in survivorship, is it not?
Yeah, and we try, when we sit around at Cancer Committee and map the strategy for our program, we think of cancer prevention in one arena and screening in another. So prevention issues go to smoking cessation programs. There's a number of cancers, way more than just lung cancer and head and neck, that are associated with an increased risk with smokers. So smoking cessation programs are a huge part of a healthcare system's responsibility to teach our patients and help our patients, and do more than just mention it, give specific resources. For breast cancer, there are certain biopsies that have been performed that establish pre-malignant changes, not yet breast cancer, but put a woman at risk for breast cancer and allow her to enter a decision process with her physicians about whether she may wish to take a drug which can reduce the risk. So these are prevention strategies, are along those kinds of lines. The screening side is the sort of the other arm of the how are we going to catch this early, and there's been a lot in the press this year about changes in screening recommendations, but the Breast Health Center at our hospitals has very good policies about who to screen, how often, how to use the most modern technology to screen when it's appropriate. The colorectal cancer screening program nationwide has been pretty well endorsed by the U.S. public. That's generally colonoscopies over the age of 54 at every 5 years. And the press has been very active in reporting the lung cancer screening issue, which has come to the fore this year as low-dose CT screening for smokers at risk now enters into every cancer program's agenda.
But didn't you say that for example, mammography screenings are down? Like, why?
Yeah. So what we've learned is that even on Long Island, where you would think, we think that that breast cancer is a topic that's been very much in the fore on Long Island. There are certain pockets of the population that are extremely well versed in screening, and then we're not reaching everyone.
And we need to reach them, and hopefully they're watching right now and saying, I need to get that mammography.
We can do a better job.
I want to talk to you about the genetics side of this. We're going to do that after we take a break. We'll be right back. Welcome back, everybody. We're discussing Catholic Health Services Oncology Services, and joining me is Dr. Kenneth Gold, who is the co-chairman of Catholic Health Services Oncology Services. Let's get back to this subject of genetics. One of the big stories in the past few months has been the story of actress Angelina Jolie having a double mastectomy because her mother had breast cancer, her aunt had breast cancer. She was tested and was positive for the genes. How much does a story like that get people to pay attention?
Yeah, well, Angelina Jolie's story brought this topic right to the fore. This was a topic that we hear about at Good Samaritan at our breast conference on a very frequent basis. Our cancer genetics department sits at the table with us as we discuss cases, and when there's a strongly positive family history, as in Ms. Jolie's case, the potential for screening for either of the BRCA mutations, BRCA1 or 2, is done under the direction of the clinical geneticist. This is a program that's been in place at Good Sam for many years and has become quite renowned. The geneticists are part of our treatment team and are literally, as each case of breast cancer is presented at our tumor board, the geneticists are there. Sometimes their input will be requested before the patient even comes to surgery if the type of surgery might be affected by the results of genetic information. So
what does that mean? Does that mean whether there'll be a full mastectomy or whether there'll be, what does that mean?
Right. If in the case where, like in the one that we were discussing with Angelina, the potential for prophylactic bilateral mastectomy because of a very high lifetime risk will be discussed, and our reconstructive surgeons will be, of course, part of that discussion, so that the whole interaction between genetics and cancer has become just an explosively important topic. The topic of the gene mutations that we've discussed, these are germline inherited mutations that place a person at increased risk. In this case, for breast cancer, there are similar kinds of situations in colorectal cancer with other genes. But there are the inherited genes that speak to risk, and then there are the genes that develop at the time of the tumor cell growing. These are called oncogenes. And these are genes that will speak more to therapy-related decisions as opposed to the screening side.
Right. So, meaning that your risk could be greater, but you may never develop the cells. with the first, but with the second, you've got the cancer.
And it's speaking to specific properties of the cells that can be addressed with various therapies, right?
What are the risks genetically? If your father had colon cancer, what are the chances that you could get colon cancer?
It goes up, if it's just a single first-degree relative, it goes up to the point where screening is pushed back to age 35. But the lifetime risk there is nowhere near what the established inherited cancer syndrome risks are. Lynch syndrome is the disease that we talk about for colon cancer and the BRCA mutations in breast cancer. The field has become very complex, and that's the reason why we've encouraged our patients to have full appointments, consultations with the cancer geneticists. They spend the better part of half a day, and the decision about whether even to screen is a very highly individual one.
Because based on the person or based upon the recommendations from?
Some people might not want to know, but they certainly need information.
Right. Well, would you want to know?
I would want to know.
Yeah, so would I think. But then you've got decisions to make based upon that knowledge.
Right.
But again, the risk factor, so say that you had more than one person in your family who had a type of cancer, and what if it came from both your mother and father's side? Then your risk is pretty intense.
Absolutely, and when the geneticists issue their clinical report after these consultations, they, in addition to discussing the screening, whether the test is going to be done to look for the gene, they estimate future risk, and the body of the report concludes with an individual screening plan for that individual.
Meaning you will be screened every 2 years,
Right,
every 5 years, you'll have this test, this is the danger.
And it may be with different equipment too, like breast MRI, for example, in a patient who carries if for someone who chose not to have the preventive surgery, the screening, once the gene is identified, would be with MRI. We're not sure that MRI is necessary for every member of the public, but for those high-risk groups, that kind of specialized technology.
So, again, this is all relatively new, all over the past decade or so. What do you anticipate we will see going forward?
Yeah, on the treatment side, it's really interesting what's happened recently. The surgeons, who are really the quarterbacks of most of these cases, have gone to a general trend in which less invasive surgery with much faster recovery times has allowed patients to move past their operation and return to work. Sometimes I'm shocked by how quickly the recovery has happened.
But is that less invasive surgery still as effective?
Yeah, and the data is looking crystal clear that laparoscopic colon resections, for example, for colorectal cancer, are turning out with just as good long-term survival rates as the open procedures. The surgeons have been wonderful in the general trend from mastectomy to lumpectomy. When it comes time to examine the axillary lymph nodes under the arm of a woman with breast cancer, now the procedure that's being done at all of our hospitals is what's called a sentinel lymph node biopsy, where you can sample several of the first draining nodes, find out on the spot whether they contain tumor cells or not, and stop at that point. We no longer, in most cases, do we need to do full dissections of these axillary lymph nodes, the procedure that puts patients at risk for lymphedema. That should be something that each program sees a drastic decline in, and lymphedema, we hope, should be an entity that doctors hardly see.
That would be great. So in terms of survivorship, the survivorship rate is up, correct?
Yeah, there are more and more cancer survivors, and as Dr. Maratra had mentioned, all of the hospitals in the system, all of the hospitals throughout the country are being asked to do an even better job of coordinating the care of patients as they return to the community. Their episode of of care all the way from their initial diagnosis through their surgery, radiation therapy if it was required, chemotherapy, often hormonal type therapies in breast cancer patients. They return, they're through the episode, and they're back. They may be back with a number of issues that should continue to be addressed. They may have nerve numbness or tingling from a drug that they received. They may have muscle weakness. They may have gained weight because some of the drugs that are required to keep the risk of recurrence as low as possible might be associated with weight gain. So the number of people at the table in the cancer committee reflects how broad and multidisciplinary this effort has to be. The registered dietitian is a resource for that person. The physical therapist, I feel, is a key member of the team to really be back after going through a year or 6 months like that. We're trying to have patients see our talented physical therapy department as much as possible to tailor sometimes very specific. It's rehabilitation.
Yeah.
It's really cancer
Sure.
rehabilitation.
Because they've been in a place where they haven't been able to engage in their regular activities. Yeah.
There are workplace issues as they return to a productive life. There are financial issues. There are emotional issues. And we have learned from the community of survivors that as patients are segueing from the acute frequent care, the chemotherapy on day 1 and blood counts on day 10 and hair loss and all of the kinds of, once you're through all of that, the handoff, the oncologists and the radiation oncologists and the surgeons will remain involved. But as the patient is handed back to the community physician who's in charge of their care, we're being judged in a beautiful way now. We want to give a very specific, tailored plan. What are the issues for this individual?
Again, so that would mean that while the therapy or the treatment might be really personalized and customized, so now is what happens after cancer
Very
part.
much. Everybody's got a different story. If you received a chemotherapy drug that can affect heart function, that's something that your primary care doctor needs to know, and what's the plan going to be going forward with that? The cardiologist might need to be involved. The dietitian, again, in my mind, plays an incredibly important role. We're now learning that the recurrence rates for breast cancer can be influenced by the ingestion of more and more fresh fruits and vegetables. Well, that's really important information.
Absolutely.
And we want to do a really good job of getting that information out at the primary care level too.
Sure, which means this is why you've integrated all of this.
Right.
So at the end of the day, you've got 30 seconds. Last message for people watching?
The research, the clinical trials that have shown best practices have yielded some beautiful results. We haven't won the war on cancer, but we've made a lot of progress. And CHS is looking to integrate these great developments system-wide on your behalf.
We love that. Thank you so much, Dr. Gold. It was a pleasure to have you here.
Thanks, Jane. It's a pleasure.
Thank you all for watching, and if you would like any further information on what you saw today, you can log on to our website at chsli.org. I'm Jane Hansen, wishing you goodbye and good health.